The stark visual contrast on screen illustrates a profound physiological failure. On one side, normal anatomy. On the other, a severely swollen limb. This physical distortion is the direct result of fluid escaping its intended boundaries. To understand how a human body reaches this state, we have to trace the water. We will deconstruct this condition starting from basic cellular fluid compartments, moving down to the hemodynamics of individual capillaries, and finally outlining the clinical strategies used to correct the imbalance. This definition box establishes our exact clinical parameters. Edema is a sign reflecting the sequestration of water and salt, specifically in the interstitial sector of the extracellular compartment. Biologically, it requires an increase in interstitial fluid volume of at least 30% before it manifests visually. A common diagnostic error is treating this swelling as the disease itself. Edema is strictly a symptom, a secondary physical readout resulting from various underlying etiologies. Addressing the surface-level swelling is ineffective without identifying and diagnosing the precise systemic failure hiding beneath the skin. We begin with a baseline metric. The human body is primarily a water-based machine. Fluid accounts for a full 60%. This chart maps those exact spaces. Fluid does not sit static in these zones. It exchanges continuously. Passive osmotic gradients and active ATP-driven pumps drive water and electrolytes back and forth across cellular membranes to maintain volume. The exact continuous regulation of that 75-25 split between the interstitium and the plasma is the only mechanism preventing our tissues from drowning in their own water. Shifting perspective down to the microscopic level of a blood vessel, we find the physical barrier dividing the plasma from the interstitial space. Hydrostatic pressure exerted by blood volume pushes fluid out of the capillary. Opposing it, oncotic pressure from plasma proteins pulls fluid back in. This gradient shifts along the capillary. Outward hydrostatic force is highest at the entrance, dropping significantly by the exit. The critical rule to remember: hydrostatic pressure pushes out, while oncotic pressure pulls in. Normal human life depends entirely on this perpetual microscopic tug-of-war between hydrostatic pushing and oncotic pulling remaining balanced. This tug-of-war is formalized mathematically in the Starling equation, governing capillary fluid exchange. Net filtration pressure calculates these exchanges, weighing the combined forces favoring filtration out of the capillary against the forces favoring reabsorption back into it. This flowchart illustrates the breaking point. Edema occurs when equilibrium fails, when increased filtration pushes excessive fluid into the tissue. Note the green lymphatic system block, acting as a critical overflow drain. A failure in this specific drainage network rapidly accelerates fluid accumulation. Edema is a mathematical failure. The body's internal plumbing produces a larger volume of fluid than its emergency drains are capable of clearing. We can trace this mathematical breakdown to 4 specific underlying causes, mapped out in this diagnostic panel. The first mechanism is an increase in hydrostatic pressure, occurring when elevated venous pressure physically forces more fluid out of the capillary bed. The second is a decrease in plasma oncotic pressure. In severe liver disease, insufficient albumin production means fluid fails to return to the vessels. The third involves increased capillary permeability, where inflammation allows fluid and vital proteins to leak directly into tissue. Finally, the fourth mechanism is decreased lymphatic drainage. Physical obstructions or damage to the lymphatic vessels trap the normal fluid overflow, preventing its return to circulation. Regardless of how complex a patient's chart appears, their edema can always be traced back to one of these 4 fundamental mechanical failures. We now translate these microscopic mechanisms into their macroscopic presentations on the patient's body. This classification table breaks down severity. Localized edema is confined to a specific region, indicating local disturbance, while generalized edema involves multiple areas, pointing to systemic imbalance. Column 3 details anasarca, the extreme result of diffuse retention, causing massive fluid accumulation across tissues and organs. Pay close attention to visceral edema. Swelling that compromises the internal organs, specifically the lungs or brain, is a critical severity factor that demands immediate, life-saving intervention. The physical distribution of fluid provides an immediate readout. It tells the clinician whether they face a minor local disruption or a fatal systemic collapse. The primary objective of clinical evaluation is not to measure the extent of the swelling, but to uncover the exact underlying mechanical flaw driving it. The diagnostic process begins with anamnesis, carefully collecting the patient's history regarding the onset and evolution of the swelling, while checking for associated warning signs like dyspnea. During the physical examination, clinicians look for the Gade sign. Applying sustained pressure to the area leaves a distinct, persistent depression in the tissue, physically confirming the abnormal accumulation of interstitial fluid. This diagnostic flowchart connects the physical findings to paraclinical tests. Laboratory analysis of renal function and protein status is required to confirm the physical data and identify the etiology. Careful physical and paraclinical evaluation is the only structured method to decode the outward symptom and expose the true internal pathology. Once diagnosed, the core management principle is direct. You must treat the underlying mechanism to restore the pressure balance, rather than simply draining the accumulated fluid. This memory box outlines the strategy. Target the cause, restore balance, eliminate the excess, assess through follow-up, and treat the exact mechanism. Specific mechanical failures require targeted strategies. For example, treating a decrease in plasma oncotic pressure specifically demands therapies that correct vascular leakage or replenish severe protein loss. Effective management acts exactly like an engineer fixing a broken system. It repairs the specific pump or seals the exact pipe that caused the flood. Looking at this master memory map, we trace the complete physiological arc. The pathway is strictly linear. An underlying cause triggers a mechanism failure. This disrupts fluid balance, leading to interstitial accumulation, and finally, the physical sign of edema requiring targeted management. Maintaining normal physiology is an invisible, continuous balancing act of Starling forces that can be tipped by a single failing variable. Mastering the pathophysiology of edema transforms it from a generic, confusing symptom into a precise and navigable map of internal failure.